So this course, if you like, is essentially the summation of my 40-year love affair with herbal medicine. No herb that I have ever worked with, and I started working with echinacea right at the very beginning, there's no herb that I've ever worked with that has done as much good when it's been knowledgeably prescribed than the herb echinacea. Echinacea, we would say, is incorporated in the formula to help resist infection. It is not a traditional antibiotic. It does not attack bacterial or viral activity, but what it does, it stimulates all the resistant mechanisms of the body. It rallies the immunology of the patient and supports the body's anti-infection activity.
This is FX Medicine. I'm Andrew Whitfield Cook, and joining us today is Brandon Brock, Dr. Brandon Brock. Doctor, how many doctors does this man have? But anyway, let me read his bio for you. He's a clinical practitioner in Dallas, Texas, in the fields of orthopedics, neurology, and integrative medicine. He has doctorates in family nursing practice and chiropractic, as well as postdoctorate orthopedic training from Duke University, with additional training in molecular and nutritional medicine. He's a diplomate in functional neurology and nutrition, holds board certification in integrative medicine, and is a global research scholar from Harvard Medical School. And he's currently working on another PhD. Dr. Brock is on several clinical advisory boards and lectures for several various companies on a multitude of topics. And I warmly welcome my friend Brandon back to FX Medicine. Brandon, welcome. How are you?
Hey, it's good to be back. Thank you so much for having me. And I miss Australia badly.
I miss you, bro. Now, I mean, you and I can chat just for hours, but we need to talk about a topic which is a sad scourge. I mean, we're saying it's a sad scourge in the changed landscape of today's COVID-19 virus, but you know, the scourge of neuroinflammation and the various diseases which accompany it are going to be the new key killers for particularly our elderly. So I guess to start, you know, you're a clinician. So when you see a patient walk in to your office, what are the key signs, the key clues that you go, I really need to delve further here?
The fact that they walk in, our practice has evolved so much. I get it from the beginning, the entry forms that we use, and I studied that before the patient comes in, and you see so many chief complaints. You know, there's really not a way to link it all, usually not, at least not a way to link it into one sort of simple condition. So a lot of times they have one thing leading to another, and then it kind of all boils, you know, together to make one syndrome, and then that just explodes into a group of symptoms. And that is a lot of what we see. We have to unravel these mysteries that have been presented to us that have really they sort of failed a conventional model, so to speak. Meaning one pill or one procedure or even a multitude, polypharmacy, won't necessarily correct everything. So we're stuck having to do a lot of diagnostics and look at it maybe from a different perspective. And sometimes we use traditional and non-traditional models. And so I tell you, it's really, really cool to be here. I see lots of people popping up, and I just want to say hi to everybody that's saying hi. So,
yeah, absolutely, and from around the world. So, welcome to everybody from Australia and the US.
I just saw somebody from Texas pop up. I can't believe it.
So, with regards to the patients that you see, Do you have to very often go back to step one and go, okay, let's just do the basic assessments again so that you can get a feel for what happens with that person? I'm looking at you having a little conversation with Anne-Marie Sullivan there.
Yeah. Yeah, you know, to answer your question is yes. I mean, listen, one of those things that happens very, very common is patients walk in and they put a bag of stuff here and a bag of stuff here, and they've got tears in their eyes and their checkbook is empty and they've spent, you know, hundreds of thousands of dollars. And we really, and that is a culmination of practitioners not communicating with each other, which, you know, I'm just as guilty as anybody else. But sometimes we have to just stop, back up. And I'll give you just a real quick scenario. Last week, I had a girl that came in that was really suffering tremendously. And come to find out, she was just really in a terrible relationship, had a terrible amount of stress in her life, had an enormous amount of adverse childhood events with very little resilience. And this was triggering all kinds of pathological physiology within her body. And nobody had ever stopped to just dig a little deeper and ask her that question. And that was really, I think, one of the starting points of her disease. It's really interesting. You know, the literature is showing us now that children with adverse childhood events that lack resilience, up to 60% of those individuals will be hospitalized at least once in their lifetime from an autoimmune disease. So we go all the way back to how were you raised? What was going on? You know, what did you experience? And since we've started doing that, we've been using psychological intervention with the appropriate practitioner that works with me, and it's been fantastic.
So with regards to sustained inflammation, which I guess, I mean, this follows on from your friend Datis Karazian at the Bioceutical Symposium. And he spoke about early damage, early neurological damage, and then prolonged inflammation, or a priming can be set in place where prolonged inflammation leads to a disease many, many years later. So which tissues are most at risk for that early insult, that early trauma? Can it be any tissue, like, for instance, you know, a football injury? Or does it tend to have to be a neurological tissue that's damaged?
Well, what's really interesting is you can get peripheral inflammation from trauma, or from your guts, or from a fungus, or from a parasite, or from a virus, anything that creates systemic inflammation. And if it ends up creating something like, you know, any of the interleukins, and I don't want to get too much into the immunology, but like, let's say a Th17 or interleukin 17 response, and it sort of starts to open that blood-brain barrier. And some of that peripheral information or inflammation gets into the central nervous system. And it really just says, hey, brain, become inflamed. So now you may already have trauma from, say, playing football or even soccer, or maybe you got into a bar fight. I don't know. It could be any of them. Maybe it's just inflammation from the fact that you have an infection in your central nervous system too. But when you combine the two together, it starts to change the cells that control the environment of inflammation. Without making this too complicated, it changes them genetically. And they can't turn each other off, but they want to stay on. And so typically with some of these injuries, they stay on for a certain period, they clean things up, they connect everything back together, and then they kind of turn off and they're like, okay, cool. But the more we have inflammation that is sustained, whether it be in the periphery or the central portion, and that's why we like to check the blood-brain barrier. It's so cool because we can see if there's that, you know, peripheral gut inflammatory pathology and those LPSs that are really getting into the system, making interleukin 6, coming into the central nervous system, changing microglial cells for over 30 to 45 days. And then the next thing you know, you've got sustained problems.
So it seems to me like, you know, one of the issues of this sustained inflammation is very much like tolerance that we speak of in the gut. And we need to probably start at the gut, but it seems like tolerance is the key, the switching off of our immune system.
Yes, that would be 100%. It's not as simple as what we thought it was. We now are running genetic panels. And some of these genes that we're running show that some people don't have the genetic capacity to really switch off microglial cells. And in fact, some people have the inability to control microglial cells genotypically and phenotypically. And then their interleukin 6 also is out of control. So it's much easier to become inflamed. So what happens is you get this situation where, man, I tell you, you can end up with, hold on a second here. Something popped up on my screen.
Yeah.
Oh, I'll just read through it. Anyway, you get a situation where, whenever your brain gets inflamed and all these things are happening and you've got these genetic markers can create a situation where it's not as easy to treat as people think. And so in other words, it doesn't follow the guidelines per se. And so we like to look at new genetic markers, not just apoenzymes, but we look at a few others that are kind of, underneath that will say your microglial cells are going to stay on. Your brain-derived neurotropic factor that makes it grow is not as good. Your interleukin 6 is going to really turn on, and the gene that actually stops that is not there. And so now you're much more prone to that entire story that I just told you about, and that will help us with the dosing in regards to our nutrition or our medication. And sometimes we dose people higher based upon their genetic needs.
Okay, I guess what I'm asking though is, when we're looking at interleukin 6, there's a number of disorders that can have increased inflammatory markers, interleukin 6, CRP, whatever. How early should we be, I guess, checking patients who come in for potential inflammation or neuroinflammation in their, later years? Is there any keys? Is there any clues that we can have earlier on in their patient history to go, oh, you're really at risk of turning this on? Or is that just to do with family history?
Well, we've kind of done it this way. We have started looking at people genetically and saying, you are very prone. So right. We do not want you to become infected. We want to watch for viruses. We want to look, for a fungus. We want to look for trauma. And you may not, we've actually identified some people now where we're like, hey, you're a bad candidate for trauma. So please don't go play football, because you might be very prone to interleukin 6 just wrecking your life. And, when you look at this and you look at the way microglial cells can differentiate and change, if they're not regulated both by their internal environment, their genetic environment, and your own internal genome, they can switch on to two different types of cells that are supposed to work together, and they end up not working together. So you eat things and then you end up making antibodies within your own brain. And that inflammation that is normally healthy, that cleans things out, can turn into a moment of antigen presentation. And now you get autoimmunity, and it's a bad deal.
And so is this where we're talking about the connection between M1 and M2 macrophages and the M1 and M2 microglia?
Yeah. And whenever they're always at interplay, and they're always working together. But when you become, primed, or there's a genetic change and you have sustained components of inflammation, microglial cells have to jump into action. And so M1's going to do one thing, and M2's going to do something different in a normal state versus an abnormal state. This is where we end up getting a situation where, especially if Th17 is involved and things are coming in constantly into the central nervous system and making these two things diverge and not do what they're supposed to do, and promoting not just more phagocytosis, but more antibody antigen responses. It's just a matter of which tissue is going to become involved. If it's your basal ganglia, you might get something like PANS or PANDAS. If it's your cerebellum, you might get something like, some sort of, gait disorder or cerebellar disorder where you don't swallow good, you don't talk well, and you're just coordinated in regards to your overall condition. And then there's other things. It can affect all kinds of neurotransmitters as well, and receptor types that deal with weakness, fatigability, neuron fatigability, and so forth. So there's really cool panels out now that will tell you that if this process has happened, you can see which systems have been tagged, and you can work backwards and say there's inflammation, and say, if there's inflammation, what's causing it? And you end up finding something like a major fungal infection or a virus.
Gotcha. Okay, can we discuss those panels a little bit? Because Datis Karazian alluded to this in a podcast I did with him.
Yeah.
So what sort of
well, there's different companies out, and they're really all good, and there's different types of technology. And in the States, we have something called FDA, which is kind of the gold stamp. And one of the labs that I use has just compiled basically multiple tissues, whether it be brainstem, receptors, neurotransmitters, and so forth, even the blood-brain barrier, and even the organisms that are commonly found in the central nervous system, like cytomegalovirus and so forth. They can create a little bit of encephalitis or inflammation in the brain. We like to run these panels, and then I can run a mold panel with it, or I can run that panel and I can run a viral panel with it, or I can run that panel and I can run heavy metals with it. So you kind of look at the patient, and I look at their underlying basic labs, like their CBC and their comp bio and stuff like that. And then off of that, and off of their history, I decide if it's central nervous system wise, I decide which way I want to go. So like the other day, I had neurological problems and thyroid. And so the cool thing is well, not cool, but the bad but yet interesting thing is that we got this person's thyroid completely under control, but we didn't realize, or we do realize now, is that there is a genetic SNP where even if your thyroid is perfect, it doesn't work well in the brain. So this person still had the neurological symptoms of thyroid, but that gene was homozygously positive. So it was still a problem neurologically for that person. So we had to start doing other things for that person, even though their thyroid was under control, even though their antibodies were dropping, even though we gave them every micronutrient to support everything that was going on, even though we were watching their flares up and down, it still wasn't working in the central nervous system.
That would have been frustrating. That's almost chimeric, isn't it? Two people.
Well, it's really interesting because it explains a lot of patients. A lot of patients are like, hey, look, everything is going great. I quit losing my hair. My skin's doing good, but I don't have good conversion in my central nervous system of T4 to T3. So then we have to change compounds that we give them, and it works out great.
Now I've got a question here. Which SNP? Fox, as in FOXP3, I'm thinking.
You know what I'll do? There's about 40 of them. And what I'll do is I'll give you a list of them that you can give to the listeners, because underneath apoenzyme E, like, your apoenzymes, like the E3, E4, and so forth.
Yep.
I've got all of the dementia ones. I've got all the diabetes ones. I've got all of the thyroid ones, even the ones that deal with adiposity. Is your fat going to make you inflamed? And is that going to sustain an inflammatory state and go into your brain and cause neurological issues? Now, real quick, we're seeing this right now with this SARS-CoV-2 situation, where you're supposed to have an interferon gamma response that actually resolves these viral titers. And so what happens is you become more inflamed if you're genetically prone to have an imbalance between adiponectins and leptins. And so when that happens, you can't brush off the viral titers down, and they end up making a larger tumor necrosis factor-based cytokine storm, which goes into the central nervous system. And if it's already primed, you're in very big trouble. The virus can also sneak into the central nervous system, go into your brainstem, affect different areas of your brain that control your breathing. And now you can't breathe because of a central nervous system problem, not just an alveolar problem.
Wow. So hypothalamic dysregulation and wow, that's terrific. You mentioned something earlier about ApoE, and this really interests me and still confuses me. Is it basically like choose your disease, or are there other factors underlying ApoE which magnify its pathogenicity?
Yeah, I'll give you one example. There's ApoC1. Which if you have that along with ApoE, it's way worse. And then there's TREM2, which makes you tremendously greater. So if you're ApoE4, but everything below it is great and your suppressor genes are really good, the E4 is not near as dangerous as a E2, E3 with all the other genetic components that are turned on, and the lab that we use will show what is the odds ratio that it will give you, like say dementia, and you can add those odds ratios up and you can start to see a very grim picture or non-grim picture. And it will help us dose the things that we want to use. Like if you want to use sulforaphane, for instance, well, we can dose it up. It's not dangerous per se to dose it up.
Right. And what about other factors in outside of ApoE? What other sort of SNPs do you look at, neurological SNPs?
Well, what's really interesting is we're finding out now there's SNPs that are good. So we've been looking for the ones that are really, really bad, and if they're on, then you have a greater chance. But there's some really powerful genetic components that will inhibit negative things. So we're outlining those as well and evaluating those. And if those guys are turned off and the bad ones are turned on, and then you have an underlying inflammatory response that is stoking this, there's nothing preventing your tissue from becoming excitotoxic and destroyed and you losing brain volume. You know what I mean? And so once that happens, mainly in the frontal areas, you asked this earlier, which areas are most prone, like frontal areas near the blood-brain barrier where it's the thinnest, and then our lateral convexities. This is where your typical Alzheimer patient will get damaged. And of course the hippocampus. Okay. So anyway, and I see over here that genes really can be the final layer to the opinion, and that is true. And I see that a lot of people are, kind of happy that we're starting to bring genes into it, because genes are the variable that makes every one of these standardized cookbook sort of routines for treatment invalid. And that includes functional neurology, nutrition, or medication. So I have some very unique patients. Just a quick story. I had a guy that came in last week, was getting very rapid dementia. All of his genetic receptors for being estrogen sensitive, for low estrogen, even as a man, were very, very, very prevalent in him. He was on hormone replacement and was taking some medication called anastrozole that drops your estrogen down. So your testosterone goes up and your estrogen goes down, so you feel more like a man. And that medication, as his estrogen went down, his dementia went up. And we saw that genetically. We took him off that medication, allowed his estrogen to go up. He didn't get any gynecomastia, and he started to snap right out of it. We would have never done that, ever, without seeing a picture of his genetic profile.
Right. I'm going to ask a question from Sarah Riley. So have you found Lyme patients oftentimes have anti-myelin oligodendrocyte glycoproteins or antibodies or other demyelination autoantibodies due to the cross-reactivity of Lyme?
Yeah, that's an interesting question. The cool thing about Lyme is we're finding more and more and more and more species of Lyme. And what I'm finding is, a lot of people do Lyme, they do Lyme titers and all this stuff. And then they do a CD57 count, which is really sort of a fancy way of looking at some of your natural killer cells. And then we look at 50, 30, 20. When those get down really, really, really low, we start seeing the blood-brain barrier get really destroyed. We start seeing peripheral and central myelin-based disorders. And in some situations, we have found it as the perpetuator of a PANS or PANDAS reaction. It's not strep. We've seen mycoplasma and we've seen Lyme. So, I do a dual test for Lyme. I'm kind of paranoid about it. I always want to make sure it's there because the treatment for it is really difficult. But when it's there and they have the arthralgia, maybe very seldomly do they have the bullseye rash. Very seldomly do they remember the tick bite and all that kind of stuff. But we have found that it cross-reacts with a multitude of tissues, in particular, the plastic coating on the wire per se, whether it be oligodendritic or whether it be a Schwann cell and so forth. But it's not just those. But we've seen it heavily in the basal ganglia, especially to the D1 pathway, if that means anything to anybody. It just makes people very, very volatile, out of control. And for those of you that are dealing with PANS or PANDAS patients, these reflexogenic basal ganglionic inflammatory encephalitic based mechanisms, they usually go in 20-minute intervals. So just give them 20 minutes. You're not going to be able to discipline them. They don't understand it. It's a neurological reflex. Just back off. Give them 20 minutes. They'll usually just resolve.
Question from Rebecca. I'm really interested to know what kinds of infections, now you've already mentioned two, can impact the brain or CNS directly. So we've mentioned CMV, you've mentioned Lyme. Can I just add a little bit onto that?
Sure.
Does it always have to be directly affecting neurological tissue or directly crossing the blood-brain barrier? Or can it be a peripheral infection and then the signal is sent via the danger-associated molecular patterns?
No, really interesting stuff. So let's take MERS, for instance. MERS will crawl up your neurological pathways into your central nervous system like herpes. Mm-hmm. And that's why MERS has a 30% case fatality rate. It's right. Devastating. Cytomegalovirus or any virus certainly create peripheral inflammation. And if we measure your blood-brain barrier antibodies and they're really terrible, and that's getting through, it might as well, it's just going to go into your central nervous system anyway. But we have cytomegalovirus, we have, Epstein-Barr that can, be convalescent or non-convalescent and so forth. And then we have HHV6, HHV7. And what's really interesting about cytomegalovirus is it neutralizes neural progenitor cells. So you lose brain volume much faster whenever you have a cytomegalovirus and inflammation. When you get the cytomegalovirus down, you don't have as much volume loss because your neural progenitor cells can actually be produced at a higher rate. And that's really a cool piece of literature that we found recently.
Now, there's one from Marty here. How do you treat the chronically elevated EBV titers?
I knew somebody was going to ask that. Can I name drop products?
If you need to, yeah.
Well, I mean, I'll just tell you, like, one of the things I use andrographis a lot, especially in this. Listen, so let me just go to COVID real quick. It's very difficult to use just straight Th1 drivers that don't have also the inhibition or the ability to stop a storm. Like some of your Th1 drivers that are very strong, like elderberry and echinacea, they'll drive Th1 to kill the virus or to drop it down, but it will perpetuate a storm. Your andrographis per se, and your olive leaf and sulforaphane, they'll be very good at being antioxidants. They will also be Th1 drivers, but they'll also reduce the storm. Sulforaphane is a beautiful NRF2 activator, which stops interleukin-6 in its tracks. So we could really get back to it, but treating Epstein-Barr, I use biocidin, I use andrographis, sometimes if it's really acute, just to let you guys know, if it's IgM, it's acute, I'll use a Th1 driver like echinacea or elderberry, okay? If it's chronic, so if it's IgG, most people say you just got it. But if it's IgG and it's 4, 5, or 6 times the upper limit of norm, it's probably chronic. So that's when I'm going to go to my things like sulforaphane or andrographis or olive leaf, because they may have an interferon gamma type response that will lower the titer, but they'll also lower the storm. And then we can give a few other things that will protect the blood-brain barrier. So we use diosmin to treat the blood-brain barrier. This is also called dioflin. It's a prescription drug in some places, but I really think the people that take this will probably not die from heart disease in their lifetime.
Right.
It is very, very researched. Now, we've also found that some of the green tea extracts will block receptors on those ACE2 so you don't get the virus. We've also found that trans resveratrol will block that. We've also found that sulforaphane will block those. And we've also found that glucosamine that protects your joints will block those receptors. So you can actually do some stuff to where you are not going to get infected as easily in all probability. So anyway, I hate to get on that, but it's still
I think that's really interesting. I think it's really interesting that so many people have gone immune, just immune stimulation, and we really have an inflammatory sort of condition when we're dealing with COVID-19. I love to hear glucosamine come up and poke its head up, because you're now doing your PhD in cardiology, correct?
Correct.
So there was a very interesting, I know this is off topic, but I thought it was neat. There was a UK biobank study. So this is thousands of people, 40,000. And those people that had used glucosamine for over 4 years had less CVD outcomes.
Yeah. Because look, let me tell you something real quick. Glucosamine and chondroitin sulfate, so the glycosaminoglycans that are very, very absorbable, and the sulfation process, if all that is really good, it will control leptins, so you won't get leptin resistance, and your adiponectins will get regulated. Leptins go straight into the brain, and they say, okay, look, I'm hungry, but you get leptin resistance. So your leptins go up and your insulin goes up. They both go in the brain, create neural inflammation. Then they get into your central nervous system, or they get into your circulating peripheral nervous system. They go into your joints and make them inflamed. And that's why obesity and leptin resistance makes your hands hurt, not just your knees. So this is why obesity in some people genetically makes an inflamed brain, in others it doesn't. But glucosamine and chondroitin is one of those things that stops not just joint. A lot of people are like, it's just joints, but no, it's not. It actually treats a load of things. And as I was getting ready for this, just looking at the insulin resistance in the brain is tremendously devastating.
Right.
Don't get insulin resistant, please.
Well, there's a test here from Michelle, and a question here from Michelle. Do you test for leptin resistance, and what do you test?
Yeah,
do we check alpha melanocyte stimulating hormone? What do we check?
You can just test leptins, adiponectins. You can check we check peptide for insulin, and you can run glucose or hemoglobin A1C, and you can put all this together in a HOMA calculator and look at it. And you can say they're diabetic, they're type 1 diabetic, type 2 diabetic, they have insulin resistance, they have leptin resistance. And so you can see, and listen, if you have leptin resistance and insulin resistance, your brain is inflamed, end of story. Yeah. So, I mean, you can just sort of count on it, and, you know, you just pray to God that you don't have some of those other genes, because if you do, your brain is going shrink, 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 disconnection, disconnection, disconnection. And it just depends which gene, whatever gene you have that's going to express because of a decrease in firing, you may get multiple systems atrophy, you may get Alzheimer's disease, you may get whatever the case may be.
I'm sorry, but I'm just laughing. There's a comment here. Oh, to live in Brandon's brain. Spare a thought for Tara, his wife.
Yes. Yeah. Tara she should get credit for everything.
Now, I've got a question. So firstly, the question up there is, how do you address insulin resistant, it says address insulin in your patients, but I'm gathering insulin resistance in your patients.
I treat it the same way as I do insulin resistance in the periphery.
Yeah.
Just with diet, exercise, and really genetically, some people are more prone for this than others. It's just one of those things where you kind of got to starve them of the need for insulin. And we have found that fasting is very good for brain. We have found that fasting is very good for autoimmunity. I mean, 3 days of fasting can drop your antibody load down significantly. So if you're looking at somebody's labs and they're trending towards a flare, we can neutralize that by fasting them for up to 2 or 3 days. I know that sounds kind of cruel, but it will drop it down.
But intermittent sorry, you go.
No, go ahead.
I was just going to say intermittent fasting can also have structural changes in the brain. Is that correct?
Yeah, it creates autophagy. It allows, basically, if you've ever watched the show Hoarders, people that keep all the stuff in their house,
Right. Yep.
If you're doing something like intermittent fasting, it allows you to eject all of the damaged organelles, and it cleans house. So I like to do intermittent fasting after neurological trauma at a certain point, because any of the damps that you have, or the debris or the damaged cells, it helps to kind of get those out. And, it makes it a little bit easier for your brain to repair itself, and it lowers the debris fields. Now, remember, when you have trauma and you have debris fields, now that is tissue that can be eaten and tagged as an antigen antibody response. So you want to get rid of it. And so fasting might save you from neuroautoimmunity.
I want to go back to an earlier question, and it was from Sarah Riley again. Have you found anti-VGCC markers to be prevalent in patients with electrosensitivity?
With electrosensitivity? I don't know. That's a good question. I mean, we see that in people with physical activity weakness. We also see that in people that are a little bit apraxic and they have slow conduction speeds. But I've never experienced anybody. Now, with electrosensitivity, my question would be, Are you talking about like to 5G networks? Are you talking about to electric shock? Are you talking about to,
I'm going to presume that it's electromagnetic frequencies.
Yeah, the answer, and I listen, if I don't know, I don't know. And I'll just say, I do know patients that say they can feel it and they can sense it. And it's one of those things where I can't explain why, but that's a great question. And what I think Sarah should do is she should research and tell us.
What we should do is get Sarah in touch with Nicole Bilsma and Amy Skilton, who can definitely talk to them about that.
And I can tell everybody, every test I've talked about right now, especially the antibodies, I can tell everybody where to get it. I'm almost positive they do it in Australia, and the test is probably right around 400 US. So, and it's an amazing test.
Yeah.
Really nice.
Okay. Protocols for intermittent fasting with regards to days on, days off, or hours on, hours off, forgive me. So 16-8 or 18-6?
Yeah, I mean, it depends which condition. So like I said, for autoimmunity, if it's really getting out of control, I'll go 2, 3, or 4 days. If it's blood sugar dysregulation, I'll go anywhere from 17 to 24. I like to go 24, and a lot of times it'll regulate it. For insulin resistance, I'll do it 2 or 3 times a week at 17 hours. And then, you know, a lot of people just do very well with just a well-balanced diet, and they go Paleolithic, or people like plant-based. By the way, genetically, we can look at people and say, this is what you should eat.
Right.
You know, so there really is no perfect diet. Some people can't eat oxalates. Some people can't eat histamines. Some people can't go on what's called an autoimmune diet because they're allergic to a common food. And then certainly when it comes to diabetes and insulin resistance, you have to watch what you're eating. So our diets, we don't really have a diet, or every single diet is really catered to what the person needs on a genetic and pathological basis.
Gotcha. With regards to intermittent fasting and changing diets around and things like that, how aware do you have to be of concurrent medications, orthodox or pharmaceutical medications? For instance, if they've got autoimmune thyroid condition and they're on thyroxine, I know, but
no, that's a fair question. I haven't seen it really do much with thyroid medication. Now, what I have seen it mess with is insulin. And so I would tell everybody out there that if you have a patient that's on insulin, please be careful, you know, because a lot of times their standard insulin dosages, if they're fasting and their blood sugar starts to drop naturally on their own, but they're taking the same level of insulin, they can go into hypoglycemia very easily. And it's something that they've never experienced. And remember, a person that normally has, and I think these units are maybe equivalent, but, you know, let's say 100 or below is normal for fasting. But a diabetic that's on insulin is not controlled and they're used to 230. If you now bring them down to 100, it would be like me or you at 40. We would feel like we were going to, you know, pass away. So you always have to be careful. Anytime you're doing fasting, people underestimate the power of fasting. And so sometimes you have to fast with a little bit of sugar. Sometimes you have to fast with maybe, you know, a medical food that has certain vitamins and nutrients in it. So my fasting does not follow any necessarily, not any of the guidelines, but it's close, but it's also my experience with it, you know, and you learn that they may say 3 days is good, but on day number 2, you have a limbic breakdown and they can't make it to day number 3. And you need to know that. You can kind of see that patient before it happens.
Just with regards to your comment about units, for our Australian listeners, Americans measure glucose in deciliters per 100 mil. Is that right?
I believe so, yes.
Yeah, whereas we use millimoles per liter. So there's a difference there, but you can get conversion tables at many different areas. I might ask one of our moderators in the background, one of the elves, to see if they can find the sites that I found for the symposium for particularly DTIS. So there seems to on it, Melissa's on it. I found some great sites where we can look up conversion tables. Anyway, so speaking about drugs and talking about neuroinflammation, talking about, you know, I guess mainly the Alzheimer's disease, it may as well be titled and that is why has there been no gains in medications, in drug treatment for like 40 years. Why are they still hooked up on the end damage rather than the cause?
You know, we actually have there's a genetic test that will show that acetylcholinesterase inhibitors, the common medications, will actually be more harmful than beneficial.
Whoa.
We run that. And we can also say this, that Albion magnesium glycinate, and malate, we have a version of it that has multiple different types of magnesiums. The drugs like Namenda or memantidine, which are the drugs that block the NMDA receptors, it's just magnesium with a slick patented carrier molecule. So one of the things we do is we give magnesium, we sort of replace that, and then we can give some alpha GPC, and we've replaced acetylcholine. And then we give some huperzine, and we protect everything from amyloid. But to answer your question, the reason why there isn't going to be anytime soon, and the reason why everybody on this sort of live webinar needs to learn about this is because you're their only hope. That's why I really love doing like a series of classes on this, because it could be this condition that turns into Alzheimer's disease. So what one pill is going to treat that? Yeah. Oh, no, wait a minute. It's a viral condition that's turning into this. Now, what pill is going to treat that combination? So I could sit here and give you 100 different loops that perpetuate Alzheimer's disease, and multiple of them can overlap. And it's never going to happen until you can genetically change that individual. And by the way, if they have lost brain volume, it's not about reconnectivity anymore. It's about neural progenitor stem cell growth that has been altered so that when they regrow, they have to reconnect.
Yeah.
So, I mean, that's your life. It took your whole life for that to reconnect. So when you start looking at this, it's not just daunting, it's virtually impossible in the near future. That's why doing things like this, like prevention, health, looking at all the risk factors, stopping inflammation, looking at their genes, being healthy, it's all we have right now. And I really don't have any problem saying that.
You just mentioned stuff about things regarding neuroplasticity. So there's a great, he's actually in marketing in Australia. His name's Todd, can't remember his last name, but he wrote a book called Brain Hack. And he did this, it was almost like a Houdini thing underwater. Like he got out of a locked straitjacket and he taught himself to go through the steps to do that, hold his breath, to unlock, to calm down. And there was a whole series almost about brain hack. So have you got any simple exercises or simple interventions that you can teach your patients, that our practitioners can teach their patients, that help patients who have issues or who need to re-engage neuroplasticity?
Yeah, and one of the, there's probably several functional neurologists on here, and they will tell you that the person needs a very good exam, and you need to pinpoint the location and then activate that area for the greatest efficiency and the greatest good of the patient. And I would not disagree with that at all. But there's a lot of people on here that are not. And nobody else is going to practice the world of functional neurology in conventional medicine. So we might as well give some things that help out. And so one of the things I try to do is I teach a little meditation. And what's really interesting, and I challenge everybody to try this, try to close your eyes, get in a quiet room, and just think about one thing. And the second something else comes in your mind, you stop and see how long it took. If you can get to 10 seconds, you are a master.
Right.
And so that is very frontal lobe. Okay. Works great with, if you have some attention deficit issues. And then I'll just do a lot of executive function type things. So I'll pick out something that I want them to do in their health. And let's say that a guy comes in, he's 45 years old, and we could give him 50 supplements, but we're just going to give him one or two. And I will say, we're going to regiment this, and every single day you're going to do these one or two things. And that is building up to the next level, which is another thing, and then building up to another thing. And then there's some exercise, and now there's some dietary changes. And what you end up building is a pyramid of executive function, and that's frontal lobe. And so by doing that, you can change a person's life forever, but they won't do it on their own because nobody's challenged them in a way that is structured, organized, and linear. And I have found that to be as effective as almost anything that I've done in some areas where I thought I was super specific.
But that's what we need you for, Brandon.
Well, hey, we can do the specific stuff on top, but you know what? People want organization, and they don't want chaos. And so I think that even if you do enjoy chaos, there is still some linear components to health and to frontal lobe function, and you can make it from the middle out in regards to exercises, or the outside in regards to exercises. You can organize them in any way you want, depending on how well you know the frontal lobes. And you can really make some awesome, powerful frontal lobes where people will get things done, hold a job better, hold relationships better, listen better, inhibit their left brain vocal outbursts and their right brain physical outbursts. And now they're much more calm. And so these are beautiful things. And by the way, inflammation can deteriorate the frontal lobes very, very rapidly in regards to synaptic connectivity.
Mm-hmm. One thing that I've just been aware of is try and get me to meditate, and I worry about meditation. Yeah. You get me outside on a Friday night looking at a fire, I'm in the zone, just staring at a fire.
And that might be your thing, you know what I mean? I'm a bad meditator, I can tell you right now. So when I try to do this, for me, my brain is very busy. And so it's something that I've really started to work on it quite a bit, because the more I can calm that down, the more I can shift my focus and stay on one thing versus try to go to one thing and then I've got 14 other things buzzing around it. And to me, that becomes very, very unproductive, and I'm not as rapid in regards to finishing projects. So
I can just imagine Tara walking in with a flame on a phone and going, walk this way, sit.
No, it's more like a whip, getting me to do whatever I need to do. But
following on from that, what sort of resources do you give your patients for meditation practice?
There's apps on your phone that, have environment, really it's really kind of neat. For right brain, I do a lot of environmental noises. So sometimes I'll have them, listen in their left ear, and it's environmental noises, and then it can soothe down like an overactive left brain or an underactive right brain. There's also some other things we can do where we do binaural beats, where we can put them in the ear and we can find out what frequencies are going to generate the oscillation speeds of certain neurons. And then we can program that in the background of some music, and they play that. And then the background beat, the binaural beat, is something that allows them to oscillate at an equal frequency, and they can relax. It gets a little deeper. Yeah, that gets a little deeper. And then we use eye-hand coordination and visual stimulation and 3D activation and stuff like that along with that. And it starts to create a brain that will oscillate together, and we call that connection. In other words, it doesn't disconnect anymore.
Wow, that's really interesting about the music, about having the beats. Like, I'm aware of Pachelbel and other music types where they have that, it's 8 to 14 cycles per second. So it's more attuned to alpha waves.
Yeah,
calming and soothing.
Yeah, I mean, if you're really good at this and you get a QEEG and you do a physical examination and you understand all of these different sort of frequencies in music, you can program in the background of any song they want, and you can almost make it disguisable, but yet the brain will pick it up. Right. So you can change a lot of the different waveforms that somebody's having a problem with, and they can listen to it while they're doing biofeedback, and the biofeedback is 100 times faster. So, and you do that, and then if you want to, I don't know, if you can, infuse some nutrients in them that's going to really jumpstart their brain while they take some stuff orally, you can end up getting somebody's brain to perk up very, very quickly. I mean, I don't know what to tell you, but it works. I mean, we've had to figure out ways to get a brain that fatigues very rapidly to not fatigue very rapidly.
Right. I just want to cover one last question in this arena, if you like, from Ian, and that's the impact of sustained nose breathing while exercising to drive hemoglobin release of oxygen. And, this fascinates me because of the real differences of advice, if you like, that we get from meditation, the belly breathing, the deep breathing, the yogic type breathing, versus things like Buteyko breathing, the shallow.
Well, we always know this. The way I've learned this, and I may be, Ian, you can correct me if I'm wrong on this. I love watching, I watched it just the other night. I love watching some mixed martial arts stuff. And you can always tell the people who are really trying to pull all their oxygen off their hemoglobin because they start mouth breathing.
Right.
And they don't have that smooth sort of look on their face like they're taking a beta blocker. They're breathing nice. You can see their nostrils flaring a little bit. But as soon as they start to hunch over or they get into more of a fouler position and they start mouth breathing and their nose is flaring even more, they're struggling to try to mechanically ventilate things through. And remember, when you mechanically ventilate things through, oxygen is going to lose its affinity at an easier rate from hemoglobin. So I do think that's a very interesting thing. I mean, for rehabilitation, we don't see that too much. We see some people come in that have cardiac conditions, though, and that's one of the ways that we identify cardiac conditions or even respiratory conditions like COPD is they look like they've been running and they look like they're trying to pull out every single morsel of oxygen that they could possibly get.
Is this the pink puffers and the blue bloaters? Is that what you're talking about?
That's right.
The
yeah.
pink puffers,
the pink puffers are the emphysema patients. Yeah, absolutely. Yeah. We have plenty. I saw one walking down the street the other day with 2 tanks strapped to her and 2 cigarettes, one in each hand, walking down the street. I was like, that is something. I mean, I was like, I don't even know how you do that.
That's like a scene from Judge Dredd 2000 AD, you know?
I wanted to take a picture, but I would have had a wreck, you know, and then that would have been that.
Yeah. A question from Michelle regarding huperzine. Yeah. Now, this is really, it's a really interesting supplement. It sort of wavers in its evidence.
Yes.
You know, there were some trials that were really disappointing, others that were glowing. Where do we sit with this?
Well, there's a couple of things. First of all, we're really wavering about what amyloid is. I mean, some people think that amyloid, like, so, you know, you have that beta secretase that turns into a gamma secretase and it shaves off those oligomers, and you should have a monomer.
Sure.
If it's not appropriate, it turns into an oligomer. It connects together and makes amyloid, and that amyloid is supposed to attach to the cell, and then all hell breaks loose. Well, we're finding that maybe amyloid is protective against infectious disease. Okay. So we don't know, you know, and I hate to sound conspiratorial, but, you know, what I'll tell you is that there is some evidence that's leading towards that as being prevalent. And we're also finding that maybe huperzine in some of the studies is being pointed at the wrong thing. Maybe it's doing something different. Like maybe it's dealing with reactive oxygen species and intracellular function rather than extracellular environment within the brain and amyloid. We know that a lot of people feel better on it, but maybe it's not doing what we thought it was doing. But some of the literature does show that if you have amyloid, and also proline-rich glycoproteins are very, very good for the intracellular tangles.
Gotcha.
There's actually some pretty good literature on that. So, I mean, you know, you can throw some things together and kind of see what's going on. But again, you don't want to be that person that gives them a shopping cart full of, you know, nutrients.
No, that's right. Yeah. I just want to finish off on Buteyko system because Ian made a comment. It's part of the Buteyko system. There's a big difference in breathing frequency, which part of the ANS is being activated. So just along that lines, everybody register for FX Medicine podcasts because I'll be podcasting with Patrick McEwen. I think it's in August, so probably be released September, October-ish. So, yeah, make sure you subscribe to be the first to find out about that one. Anyway, so treatment stratification. Brandon?
Yeah. Well, the first thing in treatment stratification is always, first of all, establishing rapport with your patient. I mean, find out if you can do anything for this person. If you really don't feel like you can do anything, well, let me just say it differently. You have to say, maybe I can achieve this. And if they want you to achieve this, they're not your patient.
Yeah.
But if they're saying, look, if I can get this and you can help me with this, then perfect. Mm-hmm. And I think that you need to learn to match with your patient. I think that that's a really big thing. Like I had a 89-year-old Alzheimer patient that came in and she was in stage 6 Alzheimer disease. And I don't treat stage 6 and 7. And I'm like, what do you want us to do? You know, grow a brain back. We're not there yet. Mm-hmm. And they're like, no. All we want you to do is to get her to where she can give us a cue of any type that she needs to use the bathroom.
Right.
And at first I was like, that's crazy. But then I started thinking how important that is for the family. Mm-hmm. And we achieved that goal and they were happy.
Yeah.
Okay. So the first thing is figure out if you're a good practitioner and figure out if, you know, you're going to be able to deliver something that is going to be therapeutically or potentially therapeutically beneficial. Okay. The second thing is figure out what lab tests you want to do and don't run everything. Become a good enough clinician to say, I think I need to go over here. Okay. That way you're not wasting thousands and thousands and thousands of dollars, because some of that might be treatment money. But I always like to look for what might be the cause. And so I'll give you an example, just a starting example. Well, I've found that I've become an infectious disease doctor, not to my own chagrin. But a lot of times there's either a parasite, there's a fungus, there's some sort of infection or infestation or some sort of environmental factor that has gotten into the system that has created a whole load of inappropriate physiological responses. So a lot of times I have to identify those and then start to sort of reduce those things. Now that obviously can lead to a state of inflammation. In some people, just a little. In some people who are genetically prone, a ton. And it might not just be one of them. It might be a food with mold with a virus. And all of those together exceeds what they can genetically tolerate. And now you got a sustained inflammatory response. So now their skin hurts, their joints hurt, and they're starting to get brain fog. So I look at this, sort of poll over here, and there's more people that want to learn about neural inflammation. Well, one of the very first things that you're going to want to see is, do they have the symptom of brain fog? And for those that, have that kind, they'll explain it as, I feel like I'm in a cloud, or, things I just can't, it's not that I can't, they have a very difficult time putting it into words. Okay. So we go from a starting point that we have to control, inflammation that we have to control. And remember, everybody, please remember this. I'm going to probably put a lot of people in a very weird position right now. Killing off something can sometimes promote inflammation. So you have to look at this and say, do I need to drop inflammation, then kill things, or do I need to kill things and control inflammation at the same time? It becomes a very long immunological story. So what we found out is we can't separate the immune system from the nervous system. It's just impossible. Okay. So without getting too detailed in that, we control the starter, the in-between thing, which is the fire, the inflammation, and then what's going to get burnt. And in this situation, we're saying the brain. So we have to identify structures that are getting damaged, and does that correlate with symptoms? So sometimes I'll have to lay it all out, and I make each patient a formula, like cytomegalovirus plus this gene plus high interleukin-6 plus high tumor necrosis factor plus a blood-brain barrier marker that's down plus these symptoms equals Sally Joe. And then I'll take all those and then flip them and put down on the top, what is the first thing I want to knock off, the second thing, the third thing, the fourth, and then I work my way down instead of trying to treat everything at once. The reason why I do that is because if you give somebody 5 things and something goes wrong, you have no idea. But if something goes right, you have no idea. That has become the art of my life. The art of my life is making that equation and stacking it to where it's not stacked the wrong way. And so to me, that is or you could just give them this high-dose steroids and call it a day.
and leave the infection to run.
That's right. Actually, it'll make it worse.
Yeah. Marty made an excellent point. Stop the prolonged use of anti-fun gals.
That's boy. You know what? End of lecture right there.
We are nearly out of time, but before we go, there's a couple of short questions that I do want. Well, I say short. You and I are talking. I tell you, supplements. Which ones have merit? Which ones give you most bang for buck? And indeed, which ones do we really have to be cautious of? Are there any caveats that we need to be aware of with therapy? One that I'm interested in is phosphatidylserine. Now, for memory and remyelination, things like that, there seems to be some nice evidence. And it seems to, after a long lull in research, it seemed that there seems to be new research picking up, which I find interesting. Having said that, I'm really interested in its other uses, like a flag, if you like, or a tag in cancer cells.
We were literally going to make a T-shirt that says phosphatidylserine, come eat me.
Right.
Because that's obviously a nerd shirt.
Yes.
Phosphatidylserine will actually help dampen the receptors that say, come eat me, like phagocytically. So we use it in neurodegenerative diseases to slow down the volume loss. Okay, that's one of the things that we do. Plus, it's also, going to help stabilize, phospholipids and bilipid membranes in regards to a healthy cell. In regards to cancer cells, it tends to be different, where it flips up a come get me cell. And so we have to monitor that. And if we want to get into cancer, things like VEGF and stuff like that, there's a lot of people now, at least in the States, that are injecting people with exosomes that carry all these cytokines that are supposed to be beautiful. And some of them, like VEGF, can be very good, but VEGF can go up in cancer patients and allow blood vasculature to go to the tumor, so you can inject something that can bring more blood flow to your tumor and make it bigger. So this is why we're not ready for some of those things yet.
No. So you mentioned broccoli sprout extract earlier, though.
Yeah.
Right. Let's talk about that.
So that's my favorite. It's one of my favorites. Sulforaphane. We have a version of it called glucoraphan, which that's a pretty unstable product. But we have one product that you can get about 3 pounds of, the broccoli sprout extract in one serving. And if you look through the literature, just about every one of those genes is going to say sulforaphane is good. Olive leaf is excellent. We could go on and on and on. With each one of these patients, they all the treatment plans look different. We have, I use a health coach that works with me. That's Tara. She's very, very good at understanding what I say we need to do, and she works with them on their diet. And then I work with them on their, nutrition and medication and putting together their treatment plans. And we have a psychologist that works with different things. So we have a team kind of put together, and we all work in sort of one cohesive unit. And we found out that we have to, because the family members become afflicted too when somebody starts to become, let's say, neurologically declined.
Oh, sorry. Now, Bernie's question. Oh, yes. One last question. Can we talk about vestibular neuronitis for a tick, please? Yeah,
neuronitis. So neuronitis is going to obviously create a wicked case of rotational dizziness, and you got to remember, with neuronitis, unless you have another disease, it's going to feel like the room is spinning and not yourself. If you feel like you're spinning, it's probably going to be right here in your right parietal lobe, okay, or parietal insular vestibular cortex. But if you have neuronitis, it's usually inflamed, and the foramen that it goes through is getting choked off, and so you have the vestibulocochlear nerve coming down, and then it splits, and the vestibular nerve comes up, and then it splits. And the superior portion of the vestibular nerve usually gets choked off, and it allows you to have a pure horizontal, very rapid nystagmus that happens without putting somebody in position like BPPV. However, there's no hearing loss because the cochlear part is not involved. Now, if you have something that looks like neuronitis and you lose hearing, it's labyrinthitis.
Right.
Or you have an acoustic neuroma, and that creates something called Bruhn's nystagmus, and it switches directions depending on what you're doing. So to answer the question, neuronitis is sort of like trigeminal neuralgia, or it's sort of, some sort of idiopathic brachial plexopathy. Nerves have a tendency to crawl down different pathways, and it just makes them inflamed. So did you get the facial palsy, the trigeminal neuralgia, or did you get the vestibular neuronitis? And I have found it with bacterial and viral infections. Don't forget the bacteria. It actually happens.
Right. And what about, when people seem like they're having this vertigo or a neuronitis type issue, but it may be a PFO? How do you differentiate between that? You're doing cardiac stuff now. Welcome to this one. A patent foramen ovale in their heart. So how do you?
I do an echocardiogram.
Right. Okay. Gotcha.
No. I mean, a lot of times you can, if you'll get the mechanical or the electronic Welch-Allyn stethoscopes, a lot of times you can hear them.
Right. Okay.
In the systolic comportion. So as the atrium contracts, you can hear it. You can hear it swoosh over. And also they're very inefficient. And most of them, because the color of their skin when they're born will be, it should flap over, but if it becomes patent, then by the time you leave the hospital, then it's usually noticed that the child is not the normal color that it should be.
Yeah. Good point from Inga. Listen to the heart, a good exam.
Yeah.
Brandon,
and by the way, those electronic stethoscopes, it actually sounds like it really does when you're learning it on video. I mean, it's beautiful. I mean, and you can get them now that runs a single rhythm strip to your computer, through Bluetooth. It's amazing, So
we look forward to you completing your PhD and your research into this, because I think there's going to be some very exciting and practical implications for those people that are interested in cardiology. I am one. But Brandon, thank you so much for taking us through just the tip of the iceberg of neuroinflammation today. I know there is so much more to cover. Everybody, please keep your eyes and ears peeled, because Brandon and I will please. Can we do another podcast on this? So
we can go every week if you want. This material is so deep. I mean, we really could pull out just one little specific portion of it and talk about it for an hour or two. And to those of you that are out there, I want to say thanks for listening to a very broad spectrum that's not specific, but, also, thank you for, getting interested if you are, and learning. Remember, everything that you learn, whether it be detoxification or whether it be gut function or gut health or thyroid, it all plugs into the brain. It will all have an impact on the brain. So the more you learn about it, it can just plug right into this topic. So that's why I'm kind of giving the broad view, because everything that that's specific will plug right into this system.
Well, we've already taken a poll and gotten some ideas for what we should talk about next. But if people have any specific areas of interest, please let us know at info@FX Medicine or on our socials. We'd love to get Brandon involved. And the whole point of FX Medicine is to improve the skill set and the safety of integrative medicine practitioners worldwide on a non-branded platform. So please let us know how we can be better for you. Brandon, thank you so much for joining us and sharing with us your wealth of knowledge. That bookcase is in your head. I can see you don't have a look.
No, hey, listen, I just want to say thanks for having me on. This is my favorite. You guys are my favorites, man. I love being, I just love being on here, and I love your crowd and your audience, and I always love going and hanging out with everybody in Australia. It's my favorite thing to do. The plane ride's a little rough, but other than that, it's great.
Let's be honest, your friendship and mine revolves around whiskey and tequila. But
that is true. It does to an extent, for sure. We've actually sketched things out on napkins at bars, like, hey, what do you think about this? What do you think about that?
Thanks so much for joining us today on FX Medicine, Brandon. We'll speak to you soon.
Thanks everybody that joined in. Appreciate it.
And this is FX Medicine. I'm Andrew Whitfield Cook, but who cares? It's Brandon.